What I will try to do is to repeat the questions from the audience because we are not so sure about the sound. The audience is composed, it's very interesting composition, Lucy. It's a large section of parents. There are people from pharma, health authorities, as well as pediatric immunologists and rheumatologists. So it's a really mixed bag, but they're not afraid of technical and clinical details. And if you're too complicated, they will ask you. So, right, is that okay for you?
Perfect.
Good. So I think the floor is open for questions, if there are some. Otherwise, I will kick out. Alexi Grom.
The cohort of patients with systemic juvenile idiopathic arthritis, did they have any evidence of organ damage, lung disease in particular?
The question is of the cohort of systemic JIA patients, was there any residual organ damage prior to transplant?
Lung disease in particular?
Lung disease, from the top of my mind, there was none. But there was some, in the patient, there was some amyloidosis, specifically cardiac. And Lucy, do you have any comments? I'm searching my brain from
in the UK ones, I mean, it depends also what you call MAS in terms of... immediately in front of me. Paul, do you want to take that?
Well, that's another thing, of course, the high incidence of MAS flares in this subset of systemics, both before and after transplantation.
So my only comment would be about
that's not organ damage, right? Say again, Paul?
So my only comment, from my memory, Juliana might correct me, so the patients we were worried about were those that still have active MAS with liver problems, etc., cytopenias.
Yeah.
And they, one in particular I can remember, had to have some ATG before we could start transplant, and that worked quite well. I can't remember any others, but Juliana might know from patients from elsewhere that had major organ dysfunction. I don't think so.
No, none of them had major organ dysfunction, no.
No. Okay.
Are you at your center using MSCs to treat graft versus host disease for any diseases, and in particular for this?
Nora Singer is asking, who are you asking this?
I guess all of
You.
The allogeneic people. Are you using MSCs as therapy for graft versus host occurring after the transplant?
So we do. Yes, we can't make our minds up. Sometimes we use MSCs if we have steroid refractory GVHD. Sometimes we use MABs, monoclonal antibodies. Are you asking that question because you might see an additional benefit on the joints if you do that?
Yeah, well, it's the next topic also of our meeting.
A very interesting question. We've not used, so we haven't given anybody in this cohort MSCs.
Okay,
yeah, and we don't use MSCs at our center.
Okay, I may have a question from the audience, for the audience, because what we are dealing here with is really severely affected children. You've seen they have been treated with a number of medication. Also in the series from Dr. Vijs, there is a long interval between the course of between the onset of the disease and in fact the performance of the stem cell transplant. Given the fact that it's also a heterogeneous disease, is that a specific problem for parents, this uncertainty after such a long disease course?
I would say no, because the disease itself has such a great amount of uncertainty for us.
I'm not sure if you hear the replies from the audience. No? You don't probably, huh?
Not quite.
No, the remark was made that given the severity of the disease itself, this is acceptable. Okay. The question is for the autologous transplant performed in Great Ormond, there were 4 out of 5 in complete remission, right?
Mm-hmm.
Yeah.
Yeah, and that's a follow-up of?
At that time, follow-up, this analysis was done a little while ago, and I think the follow-up was average of 5 years.
Yeah, yeah.
One is as long as 15 years ago now, so, and she's now well, young woman, living independently, etc.
Yeah.
So that's the longest I know of. Paul, is that right? She was the first one.
The one that was performed at UCL?
No, the very first Gosh one.
Yeah, it's about that. It's about.
I just know Kevin was still with us, so that was 2000.
Yeah.
16 years ago.
Yeah.
Yeah. Could any of you comment on the disease heterogeneity and the need for biomarkers in selecting patients who will do poorly?
So I think that actually would be a critical thing. We struggle a little bit with the same issue in patients with what we call combined immune deficiency. So we meet patients who have variable T-cell defects. A lot of times we don't find an underlying genetic cause. And so trying to determine what their long-term outcome is so that we can decide, should we go to transplant now while the child's only 3 years old, because the outcomes are going to be better, versus trying to squeak by and see how they do, and then maybe they're 15 and have oxygen dependency because of lung disease or other problems. So if you can develop a panel that's reliable and robust, that you can predict those patients that you will predict will do very poorly, going to transplant earlier is always much better. So you can look in the severe combined immune deficiency literature, and now with newborn screening, outcomes for these SCID patients are so much better because they're going to transplant before they have infections. And while they're quite young. And so if you could get to that point, I think that would make a huge difference for your patients. Now, it doesn't mean that risk of transplant goes away. You know, it's always at least a 10% risk going into transplant. But, you know, if you have a child who's 15 with maybe oxygen dependence or kidney disease or et cetera, liver disease, you know, that child's risk may be as high as 60% sometimes.
Yeah. And Lucy, do you think there's a way to go to really predict non-responsiveness to biologicals in order to select those patients? Of course, disease-specific, of course, it's different for systemic as opposed to polyarticular JIA?
Yeah, absolutely. I think that is the way to go, because clearly selecting early the right cases who are going to need this would be a good thing, not to have to go through all those drugs if they're not going to work. I think the optimistic way to see it is that sometimes in these rare but severe groups, it's easier to get people together internationally. I mean, look how fantastically you've all come together around these issues. So I think you showed a little about the stratified medicine initiatives. Did you, Nico?
We're going to talk about it later.
Sorry.
Yeah.
It's just that. So something I think parents can really take away from this is that we need to be pushing on the doors of all trial planning committees, whether it's pharma or PI-led, doesn't matter, that discovery for the future should be built into every trial. So that isn't currently the case, and it's a real lost opportunity. So every time a new drug is in a trial, there should, I believe, be biospecimens saved that don't necessarily get used just within that trial, but can, for example, give us leads for this sort of question. So what about the children who don't do well on a new drug? How were they different from the children who do? And
it's a very good point, Lucy. After lunch, unfortunately, you will not be there. We will discuss this because we intend to make a amendment on our declaration of the UCAN meeting in London, March of this year, going in this direction. We very much in favor your point.
Fantastic. And just to say that if parents started to say, we'd love to be in this trial, but we'll only be in it if we know that you will allow discovery science to continue from it, that would be the strongest voice of all to change the whole...
We will specifically address this issue that you address. Yes. Yes. There's a question.
So if I remember correctly from your cohort a few years earlier, some of the, there was cases of MAS for the MAS-prone kids after the transplant, if I'm correct. Did that happen in the cohort that Paul Weiss has presented right now?
The question is, in the initial series that I presented, there were cases of MAS in a high incidence. Was this also the case in the allogeneic patients that were transplanted later on in time? I think that's a question for Paul.
So interestingly, no.
Yeah.
So I don't think we saw any early MAS post-allogeneic transplantation. So that must tell us something, I think. It could be infections, remember, because I think the autologous patients are more immunocompromised the way we did them than the allogeneic, because, you know, we was a full CD34 graft, so fully T-cell depleted graft, plus immune suppression. So it could have been infection in those autografts, or was it residual clones initiating the MAS again? I don't know.
Yeah.
My guess was infection.
We have to say that also after the first case, we added a very frequent and intense surveillance for early signs of macrophage activation syndrome. We saw newer cases, but as they were treated very early on, this was in the clinical setting not a big problem. Yes, go ahead.
So the decision to transplant or not is a very hard one for parents, but for doctors too. So for this cohort of patients, how did you make the decision that it was time that, you know, we saw the list of medications that they had failed, but you know, still, like, you know, you have doctors who will try on, as opposed to saying no, this is time. What drives that decision?
The question is, I think to all of us, what drives the decision, yes or no, to transplant? And that's a very difficult question that you can't answer straight on. In the absence of really accurate prognostic markers, right? Yeah. You're faced with an individual patient with a burden of the disease and an acceptance of this burden, a series of complications, and that adds to a sort of an evaluation where the opinion of the parents is very important, because you're adding risks to an unknown future. Yeah. But especially in the earlier years, that I must say, before canakinumab, before anakinra, especially systemics were difficult to treat. We tried etanercept with very poor results, and before that, we only had cyclophosphamide pulses and methotrexate and you know, Dave Sherry's protocol, and that made us initially say, well, this is almost half a transplant, which is now conventional therapy. So let's offer the transplant.
Yeah,
I apologize if I pushed this issue, but I still think, I mean, if from the charts that you showed, Dr. Marsh, I think the level of, like, you know, what is the survival rate, that's getting better. And if you look at kids who are going into MAS on a, you know, somewhat regular, but like sometimes they are, there's a cumulative risk of the MAS, and you have a certain number of medications that they have failed. I mean, I think that if you look at those factors together, there is, you know, clearly this decision was made, and I know it's a hard decision, but I'm still curious to hear from the group that made that decision as to when do you think, like, the risks outweigh the benefits? Yes, the benefits outweigh the risk. And and as time is changing with these conditioning regimens, etc., at a certain point, maybe Dr. Marsh, you can comment too, like maybe in a general way, not just for SJIA. I'm curious to know that.
I'm curious for your reply.
So I absolutely echo and agree that it's a difficult decision. And so for me, I'm lucky because I have Alexi at our center, and so I'm not a rheumatologist, and so I don't treat these patients, and I'm not up to date in all the latest MABs. There's a new MAB every 3 months, basically, and so a lot of times we'll have discussions about how sort of what your gut feeling is for this child. So when you start to worry that your child is not going to survive the next 5 years, or that you become very concerned that your child may very well live the next 20 years, but their quality of life is going to be quite poor because they're either in the hospital all the time, or they're really starting to develop lots of complications of either immune suppression or infections, etc. But at the same time, you have to weigh that, because the longer you wait, the more complications you're going to develop. And a lot of the transplant decision also really does hinge on your donor. And so when you go for a transplant evaluation the first time, we're very happy to see everyone. But I almost never make a decision about transplant until I've seen the HLA typing. So if, for instance, a child comes to me and Alexi's worried because this patient's been in the hospital 5 times this year already with 3 episodes of MAS and 2 other complications, that's a child that he will know is going to do poorly going forward, and that weighs a lot with me. That means a lot to me, that opinion. And then if we do the HLA typing and they happen to have a matched sibling, that's a much easier decision to make, because I know for that child the success rate is going to be much higher than if I do a search. And for instance, if I only have a 7 out of 10 unrelated donor, there's no way we would go to transplant with that donor, because that's not going to go well.
Do you consider cord transplantation?
We will sometimes consider cords, absolutely. You do have to use a little higher intensity preparative regimen, et cetera, but we will consider that for severe patients. And so it's really it's a process that you sort of take on with the parents, having an understanding and a willingness to accept the risk, the rheumatologist who is caring for the patient, understanding of the risk, and thinking that this is the best shot. Because you really are it's like putting your eggs in one basket. So do you keep all of your eggs in the lifetime basket, knowing that you're doling out eggs periodically and at some point you'll run out potentially, or you put all of your eggs in the transplant basket? You take a big amount of risk right now, hoping that the reward is then cure and a good lifetime. So I know that doesn't answer the question, completely, but it's.
No, but it's a valid comparison to what you said about combined immune deficiencies.
It is. We have the same problem in that disorder.
Exactly the same problem, and then you make.
Can I add a comment to that?
Yes, please.
Because I very much agree with the way Dr. Marsh described that, and what's key to the way you described it, Rebecca, is you have Alexi, and so I think where you have each other, in your case you have Alexi, but also he has you. In other words, and we have Paul Vase, so when you have an expert transplanter who feels this is one of the options, as you say, with risks and benefits attached, but has experience of that, you go and have an early conversation with them, and they will meet the parents, and that's sort of on your possible list. I think it's difficult for centres who don't have a colleague right there with whom to discuss that as part of the list.
Yeah,
and
we can say that we have learned a lot in the past 15 years.
Exactly, but it helps to discuss with the expert. The other thing that I think is an issue, and of course it's fantastic, is that we think about, even, Paul, this is true, isn't it? Even at GOSH, we now think about transplant quite significantly later than we might have done. And of course, that's a good thing, because we have tocilizumab, canakinumab, all these other drugs. And for some children, those drugs are a solution of their systemic JIA, and that's great. But it means that it's sometimes a long time, longer than it used to be, for the children to get to the point where we're even having the conversation with Paul Vase and team. And that just comes back to this need for predictive biomarkers of those who are going to need transplantation. I don't know, Paul, if you agree with that.
No, I think both yourself and Rebecca are exactly right. if you know you need to do the transplant and you've got a good marker, that helps so much. But it's very interesting. So we do, like Rebecca in Cincinnati, we do a lot of non-malignant diseases where the problem is going to occur maybe 5 years later, 10 years later, even 20 years later. And we change our minds all the time about which are the right indications. Clearly having a well child is better, but you'll see from the data probably what you're going to get, however clever we get, what you're going to get is if you do an allograft with a well-matched donor, you will make life much better for most. At the moment, I would say, I mean, it's small numbers, but you probably make life better for 9 out of 10 children, but you will shorten the life of 1 out of 10. And it's our job to try and reduce that 10% right down to 5 to 1%, whatever we can. But there's always going to be transplants that go wrong, and it's I suppose it's that risk that you weigh your non-transplant strategies up against. But I think that's a sort of crude way of summing it up. But we have so many diseases that are just the same. Successful transplant, and it looks like that's true for JIA, works very well. An unsuccessful transplant is terrible. So it's that, it's that risk that we're constantly aware of.
Okay, Paul, thank you. There's a question from the audience, and then, yeah.
So quickly, work by Alexi and then validated by a number of groups has shown that there certainly is an increased prevalence of heterozygous cytotoxicity mutations in systemic JIA. So 2 questions there. One, is there any sense that that subset of patients is a more chronic or more severe group? And 2, does that affect your decision because there may be some mechanistic insight into why these patients have disease and that it may be amenable to transplant? Would that affect your decision to bring those types of patients to transplant?
Mm-hmm. Yeah, so for instance, in HLH, if we have someone with biallelic perforin mutations, if we have a carrier, we will absolutely use that carrier donor. Same in CGD, though some people will actually argue, oh, we should never use the carrier because if you get mixed chimerism, then you have an even lower percentage. But when you go from a matched sibling donor to an unrelated donor, it's very close, the outcomes, but the outcomes are still better with a matched sibling. So if a patient with systemic JA or MAS was found to be a carrier for one of the HLH genes, I don't think I would let that deter my decision to use the sibling because the sibling offers a benefit. Now, if someone has a sibling who is only 8 months old, 9 months old, a year and a half, and you worry for some reason that young sibling has already had some questionable manifestation of autoinflammatory disorder, that would weigh into your equation. And we struggle with this with our HLH patients who have siblings that are young, and even if they're not a carrier.
The donor, I'm asking about the patient themselves.
Oh, so if the patient's a carrier, I don't think there are any data that suggests that a carrier patient going through transplant has a worse outcome than someone who isn't.
That's well, we have the series.
Yeah,
Bas and you, yeah.
Oh yeah. So what I can say is that we have looked at the variants of the known primary HLA genes in like 40 patients with MAS, and we do find, although the numbers are small, that 40% of them carries at least one variant. Some of them carry 2 variants. The one that carry 2 variants they do worse. They have a tendency to recur, and they have very severe MAS. So, for example, in this series of patients, only 2 patients went to ICU. Both of them had 2 variants in 2 genes.
So that was before transplant? Or after transplant?
No, I'm talking about the question.
I don't think there's any data.
From Scott is asking, to put it right, if patients who carry variants are worse than the other, and whether carrying more than one variant is an additional risk factor, and I'm saying that I have data suggesting that this is the case. So this patient might be considered.
Should you be looking at those types of patients as more amenable to transplant?
Because they might have a higher risk, not for the transplant,
for the
higher risk
transplant
for
decision.
the disease.
So not the transplant course, but the transplant decision.
Well, so I guess for a couple of reasons, it might make sense to consider those patients as more amenable to transplant. One, it sounds like that there are at least reasonable hints of data that these are patients that have a more
small data, small numbers.
Sure.
Yeah. But I think pre-transplant.
But the secondary to that is that if there's now some nice mechanistic data showing that gene dosage really does matter for cytotoxicity and affects synapse time and whatnot. So these might be patients who would be particularly amenable to reduced intensity conditioning.
So I think absolutely, if you have a patient with MAS that's recurrent and you do the sequencing and you find that they're a carrier for STXBP2 mutation, and that's a real mutation, and maybe you have a perforin variant as well that is real, then absolutely those are probably contributing to disease, and that would push you in the direction of transplant. You do have to be careful, though, I think, when you find these sort of variants of uncertain clinical significance, and if you're not sure what they mean, I'm not sure that should push your decision. Definitely weigh it, but I'm not sure I would let it push it.
I think both patients that you did with systemic juvenile idiopathic arthritis, both had syntaxin binding protein 2 variants.
I think only
splice
one.
variants.
I think
Could you
only
repeat
one.
the question for?
If I remember correctly, the 2 patients that you agreed to proceed with transplantations, I think both had syntaxin binding protein 2 variants, but those were splice variants still implicated in HLH, but not sort of the full pathogenic.
Yeah, definitely the one. The other one, honestly, I don't remember her having anything because we actually sent her off to like whole genome sequencing on a research basis. So I'd have to look back, actually. You may remember better.
Okay. I think John had a question some minutes ago. Still there, the question?
So I was just wondering if the age of the donor of the stem cells has any impact on the efficacy and success of the procedure.
Ooh, well, that's a question for Paul. I couldn't say.
Very interesting.
So, so specifically to JIA, I don't know. We do know, in fact, we've just been looking at all the data in the UK with adults and children receiving unrelated transplants, and there's a clear difference with unrelated donors being less than 30 as opposed to over 30. So, and of course, there is lots of data around saying younger donors do better. So we would have age in our selection, but an older donor wouldn't necessarily put us off if that was our only option. And actually, there are lots of other factors. CMV is very important. Male or female may be very important. So it is quite difficult to come up with a hierarchy. But if we have a 10-on-10 donor and there's a clear indication to use the donor, we probably will, regardless of all the other variables.
Okay. More questions? I had maybe a final one, I don't know, but do you think we could or should come up with a sort of hierarchy of drugs that we must have tried before we can offer a transplant procedure to a patient, given the development of IL-18 binding proteins, for instance, antibodies? What do you think, Lucy?
I mean, it's funny, we were asked exactly that by the National Guidelines Committee like 12 days ago, but it was easier then because there were so fewer drugs.
So let's make, let's call this a task for us as a research community.
Yeah.
The big question is whether cytoxin should be on that list.
Yeah, indeed. I mean, I think the step before that, which I know you're going to talk about after coffee or tea, is the first clear thing to do is to get together and share these samples before each of the new DMARDs, biologics, in these very difficult recalcitrant cases. And then you might be able to see some patterns of how you would direct appropriately. I don't think at the moment you could take a kind of blanket and say you must have had anti-IL-6, anti-IL-1, anti-IL-18 because it clicked. For some children, you could probably skip over some of those.
Yeah, but I'm not sure if I understand Alexia correctly. Are you talking about cytoxin 50 milligram per kg, as it was done in the David Cherry protocol? And David Cherry. Oh, sorry. Yeah, the two of them. Yeah.
I'm referring to that protocol.
Because that was quite unsuccessful. It was not published. Only the initial remission was published. I called them because that was at that time when we were setting up the stem cell transplantation, which had the same cyclophosphamide dose in it. They all. Carol Wallace told me they all relapsed later. Okay, I think in view of time, we have a short break. So let me thank all three remote speakers for their presentations. I think it was very helpful for the audience, and we will reconvene after our break. Thank you very much.